Hello, I'm Helen Zorbas, and it's my pleasure to welcome you to this breast cancer education series produced by National Breast and Ovarian Cancer Centre in collaboration with the Rural Health Education Foundation. We're delighted to have you as health professionals in rural and remote areas of Australia joining us for this program focusing on breast cancer care. In Australia, approximately 30% of women diagnosed with breast cancer live outside a major metropolitan city. As well as their cancer diagnosis, these women face additional challenges, including geographic isolation and limited contact with specialist healthcare workers. As rural health professionals, you have a vital role to play in both the provision of information and the delivery of best practice clinical and supportive care for rural women with breast cancer. We hope that through this series, we improve your access to evidence-based information and ultimately benefit the women with breast cancer in your care. The program has been developed to be specifically relevant to rural practice, and I would like to thank our facilitator, Dr. Norman Swan, and the breast cancer experts and rural health professionals who have contributed their time and expertise to this broadcast. I hope you enjoy the program.
Hello, I'm Norman Swan. Welcome to this programme on ductal carcinoma in situ. Is it cancer, Doctor? Hope to answer that question for you in a moment or two. This programme is a joint initiative of the National Breast and Ovarian Cancer Centre and the Rural Health Education Foundation, and is a project of the Supporting Women in Rural Areas Diagnosed with Breast Cancer programme funded by the Australian Government. Ductal carcinoma in situ, or DCIS, is a non-invasive tumour arising from and contained entirely within a breast duct. The incidence of DCIS has risen in the last 15 years, primarily due to the introduction of screening mammography. Women diagnosed with DCIS are actually 4 times more likely to develop invasive breast cancer as women of similar age. So we're going to cover the early detection of DCIS, current thinking about treatment, management and follow-up. You'll find a number of useful resources available on both the National Breast and Ovarian Cancer website, and that's the NBOCC.org.au, and on the Rural Health Education Foundation's website, rhef.com.au. Our panel: Brendan Coventry is a surgeon working at the Royal Adelaide Hospital with a special interest in breast surgery and breast reconstruction. Welcome, Brendan.
Hello, Norman. Hello, viewers.
Warwick Lee is the State Radiologist for Breast Screen New South Wales. He's not wearing his uniform, but I'm sure he's got one. And Associate Professor of Medical Radiation Sciences at the University of Sydney. Welcome, Warwick.
Norman.
Janie May is a rural general practitioner based at the University of Newcastle in the Department of Rural Health in Tamworth, and is an academic rural GP. Welcome, Janie.
Thank you, Norman.
Lee Millard-Newton is employed by the North Coast Area Health Service as a specialist breast nurse in the North Coast Cancer Institute and Breast Screen North Coast at the Coffs Harbour Health Campus. Welcome, Lee.
Welcome, Norman. Thank you.
Chris Milross is Head of Radiation Oncology at the Sydney Cancer Centre at Royal Prince Alfred Hospital, and is also Associate Professor at the Central Clinical School of the University of Sydney. Welcome to you all. So, Brendan, the definition, I gave a rough definition in my intro. How do you define ductal carcinoma in situ?
Well, ductal carcinoma in situ is carcinoma of the breast cytologically, but it's confined.
So it is cancer, Doctor?
It is, yes. It's cytologically cancer. That's the diagnosis, but it's confined to the inside the duct. It's bounded by the basement membrane around the breast ducts. So it hasn't yet escaped outside and become invasive breast cancer.
But it can be quite extensive.
Yes, it can. It can involve the whole breast, potentially. In most cases, though, it's confined to areas of the breast, at least one area of the breast. And
Warwick, how often is it just one area of the breast?
The majority of the time it would be just one area of the breast, but it has potential to be confined to a segment of the breast. So if it is widespread, it is usually segmental disease in the upper inner quadrant. So it's a segmental disease. That's how it grows and goes.
And if you've got it in one segment, what's the chances you've got it in another segment?
I'm sorry I don't know the figures, Norman, but it's unlikely. It's less likely because it is a segmental disease. It's usually continuous disease.
But it's a pretty wide variation there.
Well, I think that demonstrates the imprecise knowledge we have about the progression of DCIS. We know that there is a very significant proportion of women with DCIS that progress to invasive disease, but by the same token there is a certain number of women that don't progress. The problem that we have is we don't know which women they are that do not progress.
What's the incidence doing with the DCIS, Brendan?
Well, DCIS, currently there's about 1,600 women a year diagnosed with DCIS in Australia, and that sits at around about 14 per 100,000 women per population, and the incidence has remained fairly static over the last 5 years or so. It increased quite rapidly over the previous 10 years or so due to the introduction progressively of mammographic screening.
And that's the graph that we're seeing there.
Most cases of DCIS are now diagnosed within the screening program, detected by calcification in an asymptomatic woman having a screening mammogram. But DCIS was around prior to screening, probably made up of 2% of cancer prior to the screening. Now it makes up roughly 18 to 20% of all cancers diagnosed. So that demonstrates the influence that mammography has on the diagnosis.
So, Warwick, is this the polyp, the bowel polyp of breast cancer? In other words, invasive cancer always starts as DCIS or not?
Most invasive cancer starts as DCIS. The usual invasive duct and invasive lobular carcinoma starts as DCIS, yes. But that's not to say, conversely, that all DCIS ends up as invasive cancer.
And do we know what the predictive factors are? We can't confidently predict 100% of women who are going to progress, but there are features, aren't there?
Not reliable enough to determine treatment of DCIS, and it's really in the research area of trying to select out those women that we can, with DCIS, that may not progress to invasive carcinoma. But in the current state of knowledge, we cannot reliably predict those women. So we get back to the initial question, is it cancer, doctor? Yes, it is cancer.
Radiotherapy is almost universal, isn't it?
Yeah.
It's as common as surgery.
It can be treated using all of these methods. Normally surgery...
So I asked the question badly.
Normally surgery, not at all. Normally surgery is the mainstay of treatment of DCIS. Surgical excision, complete surgical excision of the area of DCIS. Radiotherapy is added in the majority of women, particularly those with higher risk DCIS. And that's really defined as removing the women of low risk, and they are DCIS that is in a small area, very well differentiated and with no necrosis being present, and also in a breast capable of being treated adequately with a complete surgical excision, so with an adequate margin of normal breast around it.
This is an area of confusion for GPs, isn't it?
It certainly is, Norman. And certainly not only is it an area of confusion for GPs, but obviously for the women who come to us trying to sort out what the diagnosis means. Because for many women, the diagnosis of DCIS sounds awfully like that of invasive cancer that their next door neighbour or one of their relatives has. And I guess it's trying to weave your way through that discussion and help them to make good informed decisions about the best way forward.
Lee, what questions do women ask you when they get this diagnosis?
They come looking, I guess, the breast nurse is one resource person where they can go to try and tease out the pathology results and offer some explanation of what is going on and lead the women to resources that they might be able to better utilise to understand what is going on with their disease, what DCIS actually is in comparison to what an invasive cancer is.
What do you think the core areas of confusion are?
Well, I think the treatment sounds awfully like the treatment for breast cancer, and the fact that once you're treated you still retain an ongoing recurrent risk of breast cancer sounds awfully like breast cancer. I think the difference, the important key difference to tease out is that DCIS has a very low rate of systemic or regional disease removed from the breast, so it's a more local issue. But as I said, for many women, this is a difficult discussion to have. The best analogy that I think we can come up for is a pipe. And whilst the cells are cancerous, they're retained within the pipe or within the duct of the breast. And whilst ever that it stays within the pipe, then that's not invasion, and that's not cancer going more distally, I guess.
What is the recurrence rate, Chris Milros?
The recurrence rate after surgery alone is in the 20% ballpark, perhaps 20 to 30%. We know that the addition of radiotherapy to breast-conserving surgery reduces the risk of recurrence down to the less than 10%, say 5 to 10% level. The recurrences that occur after breast-conserving surgery for DCIS are about half and half invasive and or a further episode of DCIS.
So untreated with radiotherapy, the recurrence rate's the same as invasive cancer then?
Yeah, it's in the same ballpark.
It's
That's
interesting.
exactly right.
But you can really dramatically reduce that. And of course, with invasive breast cancer, that's after you've had your adjuvant chemotherapy and your radiotherapy is the recurrence rate. So in fact, it's untreated invasive would be much higher than that.
No, untreated after breast-conserving surgery, the recurrence rates are about 20%, 20 to 30%, let's say.
Right. So there's a pressure here, and people talk about in other words, whether we're over-treating or not. What's your answer to a woman, Warwick, who says, can't I just wait and see?
There's two problems with waiting and see. The first, I've already mentioned it a couple of times, we cannot predict the women who are going with DCIS who are going to progress to invasive disease. So that's the first part once we have the diagnosis of DCIS. The second part is that most women that are newly diagnosed with DCIS are diagnosed on a needle core biopsy. The needle core biopsy may show DCIS in that area that's been biopsied. It doesn't tell us whether the woman also has invasive carcinoma.
Because that can coexist.
Which has not been sampled by the needle biopsy, which, yes, can coexist with the DCIS.
So the surgery is diagnostic as well, Brendan?
Absolutely. With the core biopsy, you're restricted to the areas you sample, of course. So what you're faced with is potentially a sampling error. At least with surgical removal, you can sample a larger section of it and prove that you've completely excised the area.
Lee, you've seen some bad stories with women who've watched and waited.
I think it's really important that women have that discussion with their treating team to ascertain the significance and the importance of the pathology result and weighing that up against whether they're going to have treatment or not, rather than making that decision themselves. I think that needs to be based upon informed decision making, so I don't think that can be something that the women just make a decision on their own.
Sure. Got a couple of questions coming in. A question from Kerry in Queensland. Is the use of vaginal estrogen creams contraindicated for women with DCIS? Chris, do you know?
The short answer to that question is no. There is some systemic absorption of estrogen from vaginal creams, but generally it's considered to be safe, or at least there's no evidence of it causing an increase in the recurrence of any estrogen-sensitive cancers.
Do you bother doing the ER status, the estrogen receptor status of DCIS?
It's not routinely performed pathologically. It doesn't typically make a great deal of difference to the treatment that we subsequently recommend, and in any case my understanding is that the estrogen receptor positivity rates are high for DCIS.
So there's a little theoretical reason for being concerned about estrogen, but in practice probably no. Does anybody want to add to that?
No.
A question from general practitioner in Canberra: is DCIS, well, I think we've answered that, is DCIS the precursor of all adenocarcinomas of the breast? And the answer is probably most.
Yeah, look, I think so. We know this, although there's little direct evidence, what we can say is that about 2/3 of cases, invasive cancers are associated with areas of adjacent DCIS. So that's very suggestive that it's arising from there. And DCIS itself goes on to invasive cancer in about 2/3 of cases. So you know, there's a very, very close association between these diseases, and we know that with a lot of cancers there seems to be this progression through from atypical cells to in situ tumour and then finally invasive tumour. And so this is seen with a large variety of cancers, and there's no reason to believe it will be any different with breast as well.
Let's go to our first case study. Susan's 54, mother of 2, lives in a small rural town and works at the local council. She's had the same GP, Jenny, for many years and attends breast screen every 2 years. So, well, she's probably had her 3rd visit. And on her 3rd visit to breast screen, she was recalled for further assessment. Do you ever see people after, where they're in a state of panic in between breast screen and going back for the further assessment?
Indeed, Norman. And it is a very anxiety-provoking situation to be recalled. Now, obviously, the letters that breast screen sends are very comforting and reassuring letters, and there are lots of technical and other reasons why people are recalled to assessment centres. But the majority of my patients would immediately think that this is going to be where they're going to get a diagnosis of cancer confirmed, and are very anxious.
Lee?
Yeah, I would agree with that, and I think the role of the breast nurse counsellor at a breast screen assessment clinic is to talk the patient through, or walk the patient through, the process that she's going to undertake on the day. And when she leaves the assessment clinic, is to ensure that she has an understanding of what's gone on during the day. If she has had a biopsy, to ensure that she has timely follow-up with her GP for those results, and giving clear information about what that means.
I'd agree with that. I think there's a lot we can't get through to the patient, to be quite honest. I think that we can explain things in a medical sense. Usually it takes a little bit of time for things to sink in, and to have the breast care nurse follow that up with the ability for further questioning and answers to be given, reiteration of a lot of the points that we've made during the initial assessment. I think it's very important, vital.
So, Warwick, how's the diagnosis made? So the woman comes back for
Yes. So
repeat.
So
and these days, in most jurisdictions, we're talking about digital mammography in the first instance, aren't
that's
we?
correct. That's correct. So the routine screening mammography, as I'm sure most people know, will be the 2-view mammography. Roughly between 5 and 10% of women are recalled for additional views, additional mammographic views, ultrasound, and possibly percutaneous biopsy, needle biopsy. With calcification, which is the way that ductal carcinoma in situ most often presents, there will be the mammography, ultrasound, and almost certainly a stereotactic or mammographically guided percutaneous biopsy or needle biopsy.
So here's the mammogram of Susan.
Yes, the image on the left-hand side of the screen is the craniocaudal view of the breast, and the calcification is so small you can't see it there, so we have the magnification view. And that's typical calcification of high-grade ductal carcinoma in situ. It's conforming to the line of a duct in a linear distribution. The calcification is linear and branching, forming a cast of the duct.
So when you say high grade, you mean highly differentiated?
No, high grade.
High grade. So
high grade ductal carcinoma is high grade cancer.
Right. So that's the mammogram.
That's the mammogram.
So you find that, what's next? Because it's important, Jenny, isn't it, that GPs kind of know what's going to happen?
It's really important, because then we can inform people appropriately.
Next will be an ultrasound examination of that breast. Ductal carcinoma in situ is usually not seen well on ultrasound, but if there is coexisting invasive carcinoma, it may be visible on ultrasound and not visible on mammography. You may see just pure DCIS on ultrasound, and that may aid ultrasound-guided biopsy, but usually it will be negative, and the next step will be mammographic-guided stereotactic biopsy.
Right, which we've got a picture of in a moment. How often, Jenny, have you ever seen Paget's disease of the nipple in practice?
I've seen Paget's disease once,
Right.
and I think many GPs would have seen it extremely rarely, if ever.
So here's a picture of it. Brenton, do you want to talk us through Paget's disease in the nipple, what you're looking for here?
Well, look, it most often looks like dermatitis of the nipple. There can be destruction of the nipple completely, and I've had a couple of women come in with complete destruction of the nipple. But you're fortunate usually in having the other side to compare it to, so really any distortion or cutaneous, particularly the areola region of the nipple or areola, dermatitis or obvious abnormality needs biopsy.
And so is the DCIS in the nipple? What's the story here? Is that where the DCIS is?
No. Paget's disease was, of course, initially described by Paget, and he put his name to the cells, Paget cells, which are clear cells in the epidermis. So these are a particular histologic type of cell that the pathologists recognise in the epidermis. Now, what that was originally supposed to signify was an underlying carcinoma somewhere in the breast. And it was thought originally that these were invasive cancers, and I think figures initially were put at around 80% historically. But it's nowhere near that. And but what it can signify now that we've got mammography is underlying DCIS as well. So it might be invasive or it might be DCIS, or it can be both associated with Paget's disease, or it may be Paget's on its own. So it's a marker, really.
But Jenny, if you see this is not, you don't send them to breast screen if you see Paget's disease.
No, this is time to refer directly to a
for
diagnostic
testing. And how often, Warwick, is it diagnosed on palpable lump? Well,
less than 5% presents clinically. We're probably closer to 2%. It will present
because it's so
as
tiny.
Clinically. Now, of those clinically, the most common clinical presentation will be a palpable lump or a nipple discharge, rarely Paget's disease. But all those presentations are uncommon for DCIS. By far and away, the most common presentation of DCIS is in an asymptomatic woman with a screening mammogram.
I think we've got a picture of a core biopsy somewhere. We might get that up on the screen. There it is there. Do you want to talk us through that, Warwick?
Well, this shows the duct which is filled with malignant cells. There is some amorphous calcification there which corresponds to the calcification that we see on the mammogram. The tumour and the calcification is forming a cast of that duct.
So that's, this is
and the other important thing is that it has normal surrounding tissue there.
Yeah.
There's no invasion out of the duct.
Brendan, do you want to comment?
No further.
Chris, all right. Lucy from Ashmont in New South Wales and was in Charles Sturt University. Do you think any new molecular profiling studies have progressed our knowledge of progression of DCIS, Chris?
Outside my area of expertise, I'm sorry.
It's certainly not my area of expertise, but that is certainly one of the ways of research at the moment, trying to select women who have percutaneous diagnosis of DCIS, looking at the molecular markers to select the women who perhaps will not progress, perhaps will not need further treatment, perhaps will not need excision, but at the moment it's research.
And it's a good question. It was outlined by the NIH consensus statement that's just come out, and what they were trying to do is nail down which women might not need such aggressive surgical and radiotherapeutic treatment. The difficulty at the moment is we don't have the tools to be able to select those women out so that we can save them the burden of that treatment. At the moment, we have to essentially treat them all in order to capture the ones that are going to go on and develop invasive malignancy and other problems.
But the research is being done now.
A compliment from another GP in Canberra. I like Jenny's analogy, the pipe, but did I hear right, 20% get further disease after treatment? And that's not what we said there was. It's down at 5%. Is that right, Chris?
Yes, following a combination of breast conserving surgery and then post-surgery radiotherapy to the breast. And
Elizabeth Sabok has asked how dependable or accurate are needle biopsies? It's a pharmacist asking.
They're very
If you're doing them, they're fantastic.
To answer that question, we can go back 15 to 20 years that most women who had breast cancer were diagnosed after an open biopsy. The ratio might have been, and the ratio of benign disease of cancer may have been 8 benign disease to 2 cancers. It's been turned around completely now. So the well over 80%, probably closer to 90% of women have a preoperative diagnosis of cancer, both invasive and DCIS. I think that indicates how reliable needle biopsy can be in both DCIS and invasive cancer.
So you're not missing many, is really what you're saying?
Not with, well, you have to take it with all triple assessment. I think that's key. We're talking about DCIS, which is most often detected with mammography, but really we're talking about management of cancer in women, whether they're screening or symptomatic, and we have to take triple assessment, so we don't take one tool.
Chris?
I think there's one important additional point there, and that is that the combination of the imaging evidence and the biopsy allows for careful planning of the definitive surgery.
There's also a good measure of clinical suspicion that's tied in there as well. You know, if you think that it's DCIS on mammographic grounds, and the needle sample comes back as negative, then of course it might mean repeating the needle sample.
Yes.
The core sample obviously gives you more histology, which the pathologist is more comfortable with than a needle sample, but you know, a good cytologist can give you a lot of information about the cytologic malignancy of the lesion.
So we're already getting the flavour of a multidisciplinary team here. We've got Lee as the press nurse, we've got a pathologist who's involved somewhere, he's not on a panel, there's a radiologist, interventional radiologist. Where does the GP sit in all this from breast screen? So you've done the biopsy, she doesn't get it there and then, it's got to go off to the pathologist, hasn't it? How long does it take on average to get the result?
48 hours is what I usually tell the ladies I do biopsies on.
And who gives the news?
It's the team. It's usually, though, to the GP, and the GP is key in all
So the
steps.
GP breaks the news?
Generally, although because it's MDT and a lot of us are involved, we all have to be prepared to talk about the subject. But the final results of the biopsy are often given by the GP, but in a diagnostic or a screening setting, the women are asking you questions, and so you have to be in that teamwork to supply the answers.
Is that your experience, Jenny?
I think that's exactly right, and I think women come well prepared to hear the news. It'd be very surprising for a woman to have undergone an assessment, spoken to Lee and the other members of the team at the assessment centre, and not have any idea that there's a diagnosis of either cancer or DCIS coming. So it is, I think, something where it's a matter of preparation at a number of points along the way. Often it is the general practitioner who will put the words on it and read the pathology to the patient and actually show them. But again, just like we were saying earlier, often patients aren't listening to a lot of what you've got to say at that particular visit, and it is something where I think it's something that you grow into and grow along, I guess, on a journey.
Who makes the referral to the surgeon?
Well, usually the general practitioner, particularly when we're thinking rurally. So if you live in a town where there is no breast surgeon down the road, then the decision about where you go will often be one taken in consultation with the patient about where their relatives are, what their capacity to travel is, and what their inclinations are in terms of the sorts of surgery that they may wish to contemplate.
So tell me how you decide who's going to do the surgery. What are your criteria that are in your head?
Well, my criteria is I have a book. I have a book that was put out a few years ago which actually has a list of accredited breast surgeons, and I pull out the book if they're asking to go somewhere where I'm not familiar. Obviously, you know, within any regional area you will be well aware of your local breast surgeons, your local surgeons who do breast surgery, and in consultation with a woman, then they may well go down those sorts of tracks.
What's your advice for GPs who may not see very many women in their careers with breast cancer, how to deal with this, or the sort of questions to ask, just if they're feeling anxious about it?
I think it's to arm yourself with the tools that you might be able to assist the woman. The NBOCC has a great resource that helps in that consultation.
So this is the decision-making tool, NBOCC, which we've got a picture of, and that allows the GP and indeed the surgeon to follow a track, give the women their choices.
And that becomes an information resource that the woman can actually move between her surgeon and her GP, so that she can actually discuss those treatment decisions with her surgeon once she's had that referral and goes along to the surgeon, and then they can talk about the tumour size, the tumour type, in comparison to breast size, what might be the best type of surgery for her, whether radiotherapy would be indicated, the indications for a mastectomy as opposed to conservation of the breast. All of those decision-making
so it allows all the members of the team
that.
to go through that, not just waiting till the surgeon sees her when she might not take in the...
start with the GP and have that conversation with the GP with that tool.
So that's the National Breast and Ovarian Cancer Centre. They have this decision aid tool, which you can find on their website and get a hold of one. We had a picture of it, but I'm not sure there it is there. The decision-making aid, and available from the NBOCC. Brenton, what do you think the criteria GP should use, apart from maybe the book? I don't think that book's available in all jurisdictions. I think it's a New South Wales phenomenon. I'm not sure if it's available in others. What criteria should go through your head as a general practitioner about the right surgeon to refer to?
Well, look, I think the key element is really access to good surgical facilities, and that includes good localisation techniques. In other words, the ability to be able to, because often these are non-palpable lesions, so they need some form of localisation, either carbon localisation or needle localisation, in order to be able to excise the area competently and completely. So that's on the surgical side. Also, the access to excellent pathology services, to excellent specimen radiology services.
How would the GP know that?
Well, the GPs, often get a bit of a feel for where these centres are that can provide these services. And
if you're a country surgeon with an interest in breast surgery, how do you...
They'll normally have access to that. So there's plenty of good country surgeons around that will be able to have access to these facilities, and they'll be able to send the pathology to the right places to get to breast pathologists to get the...
But you want to get a feel that they're hooked into the right network to be confident. I mean, it's not hard surgery, but it's everything that goes around it.
That's right. It's the support services predominantly that actually add to value add.
This is a team game.
Exactly. Yes. Exactly.
And how to include the GP in that? It's notoriously hard to bring the GP with you.
Yes, and it's extremely easy for them to be left out of the loop if communication lapses for any reason. So what breast screen often does, and it depends on the jurisdiction, that's granted, but what often happens is a fax goes through almost immediately containing information concerning the woman's basic history, the radiological findings, the pathology that was performed, and if there's a result, then the result can be incorporated in that if it's available immediately, which it sometimes is in some centres, particularly city centres, and also a surgical assessment as well. Now, that may end up being a different surgeon that performs a surgery ultimately, depending on the location and the general practitioner's preferences, but if all of that information at least goes back to the general practitioner, which is usually the case, then the general practitioner is fully armed then for the woman to come in the door and discuss this at a proper community level, which is really what's needed. Often the woman has been recalled back to the mammographic screening service, and it's that often alerts the woman to the fact that there's something going on here, and that it's being looked at more intensely. Usually they will start asking questions of the screening service. Is that fair, Warwick? And so some information is already going back to the woman to say, listen, I get the feeling that something's...
But you can't leave her hangingly.
No,
She's
exactly.
got to be supported all the way through this. This is a very scary time. It's probably much scarier not knowing what's going on than actually getting the news.
Very much so.
Chris, what's the treatment goal?
The treatment goal is the risk of recurrence in the breast, both invasive and in situ.
So it's preventive?
Yep, prevention of further disease, either in situ disease or invasive disease.
What are the chances, Elizabeth from New South Wales again, what are the chances of women aged over 70 presenting with DCIS? Do we know?
The rate drops down. There's about half of the women with DCIS lie between 50 and 59 years of age. So
peri and postmenopausal.
Yeah. Now, some of that may flow from the fact that screening's predominantly done in that age group, and it tends to drop off after 70. So the rate of pickup is probably more a reflection of the rate of mammographic screening. Is that fair, Warwick?
Yep.
And so there's a bit of a catch-22 in there, but the relative risk appears to decrease.
And the risk factors are the same, so if you see increased breast density, that's a risk factor, and so on?
Yes.
Alcohol, the usual
Family,
stuff.
yep. That's correct.
Parity, breastfeeding
It
history.
mirrors, well, we've spoken about it before, invasive carcinoma comes from DCIS, so the risk factors for DCIS are the same as for invasive carcinoma.
Another question from the ACT, what's the place of magnetic resonance imaging for women with DCIS?
It's a very good question. It hasn't finally been worked out. It's still a project under development. It was initially thought that MRI was relatively insensitive for DCIS, but with today's modern scanners, with the high-resolution scanners and good contrast administration, it's actually very sensitive for DCIS. It hasn't, however, come to been yet shown that routinely doing MRI, first of all, I'll backtrack a little bit. It's not a screening tool for DCIS.
It's a diagnostic
It's
or
a
surveillance.
Yes, well, yes. Surveillance only in the high-risk women, the BRCA1s, the BRCA2s.
And they're at risk of DCIS too?
They're at risk of DCIS as invasive carcinoma. So the next question for MRI scanning is, should the women have a preoperative workup with MRI scanning after the diagnosis of DCIS? Well, the answer is, at this stage, no, not on a routine basis. But perhaps in selected women, perhaps in women who've got widespread DCIS, high-grade DCIS, dense breasts. We've mentioned the strong family history. So it's in a selected population, but certainly not on a routine basis at this stage.
Brian Boring from Tasmania, a GP from Tasmania, asks what percentage of needle biopsies are false negatives? You kind of addressed it earlier.
I've addressed it.
The problems of the false...
The needle biopsies, you can break it down into whether it's fine needle biopsies, and we may be going up to, and rather than saying false negative, we'll say an inadequate result, and you might be looking at, say, 30% of the cytology. If you're going into the core biopsy, where you're getting histology, and even more so if we're using vacuum-assisted biopsies with a much wider core, the false negatives on a good sampling would be very low, less than 5%. Now, the way to make sure we don't act on those false negatives incorrectly is, as I mentioned before, is by having good triple assessment.
So how are you going to treat Susan?
Well, what she needs is, it's a relatively small area, 2 centimetres or so of microcalcification, and so she needs complete excision of that with an adequate margin of normal breast tissue surrounding breast tissue to be sure that we're clear.
So it's effectively a lumpectomy?
Effectively, yes. Yeah.
And what sort of radiation would she have?
The radiotherapy treatment targets the surgical cavity and the surrounding breast tissue and the remainder of the breast. So it's breast-only radiotherapy, and it doesn't target the regional lymph nodes in any way, shape or form. And typically when we do radiotherapy treatment for DCIS, we're talking about a course of treatment given over a 5-week period of time, somewhere between 4 and 6 weeks.
So what, 20 to 25?
25 treatments on average.
And how sick does a woman get during that? What are the sort of side effects?
Speaking as a male radiation oncologist, I'll go out on
your
a
major
limb
caveat to begin with.
and say
so no problem at all. It really is falling off a
These
lot.
ladies really don't get sick. The target is largely outside the body, and so they do develop a skin reaction, although that's typically mild, and it can be characterised by itch or heat, sometimes redness, and uncommonly moist desquamation in the inframammary fold. There's a low incidence of the general radiotherapy fatigue and some loss of axillary hair as well that's targeted with the tangential field that treats across the breast. And all of those things get better after the treatment.
Including lymphedema?
The late effects or the uncommon side effects that are listed on the screen are really quite rare. Lymphedema of the arm should not occur after radiotherapy treatment for DCIS. Having said that, you can get some edema in the breast itself, typically in the region of the surgical cavity when the breast is irradiated. And the other problems that are listed there are really quite rare.
Do you do sentinel node biopsy in women with DCIS?
Yeah, well, in Australia...
Because you don't know when you're taking it out whether anything's invasive.
No, and this is part of the problem. But the tendency in America is for a lot of the groups to do...
We should explain what sentinel node biopsy is. This is finding the first lymph node that the drainage goes to, and if that's negative, you can be pretty sure it's not gone to any of the other nodes.
Yes. So this is tracing out this single or a couple of nodes that are most likely to be the first ports of call of tumour spread if it were to occur, so-called sentinel nodes. And the rate of spread of DCIS is around 1 to 2%. So, I mean, it's extremely low. And the morbidity is not inconsiderable of sentinel node biopsy when you compare the risk of spread. So, in general, we don't. However, for widespread DCIS that involves the whole breast, for which a mastectomy might be the best choice of treatment, then sentinel node biopsy may well be a useful tool.
So it's still a matter of judgment rather than necessarily being strongly evidence-based.
Yes, and with mastectomy, of course, you're virtually making incisions into the axilla, so it's not a large undertaking, whereas for a separate area of the breast that was where a complete local excision was obtained, you might need to make a separate incision in the axilla, so there may be some morbidity in that respect.
Lee, what about and this is an issue for the general practitioner as well, the post-surgical care of a woman with early breast cancer? I know the National Breast and Ovarian Cancer Centre has been interested in this area and done surveys. There's a lot of variation around Australia in how much women get, that in the private sector they often don't get access to breast care nurses and and multidisciplinary team-based care. Just what should you be aiming for here?
I think in the context of this woman is from a rural area, that means that she might be travelling some hours to a larger centre for her surgery. And I think that it's really important that if she has contact with a breast care nurse in that larger centre and there's no breast care nurse in her area, means that she's well equipped before she leaves. There's good liaison between the breast care nurse at the treating centre, post-discharge the community nurse.
I was going to say that, it doesn't have to be a breast care nurse.
No, I was just about to say that it's ensuring there's good liaison, good communication with the community nurses. It's also it's almost like empowering the community nurse, having a breast care nurse in a folder on their shelf, so that there's a number of resources that community nurse can turn to, and particularly the ones that are available on the NBOCC website are very good resources.
Jenny, how do you follow up a woman with DCIS? What's the surveillance?
I think surveillance is one of the most important parts of it, because as Chris has said, the goal of the treatment is to reduce recurrence, and so the big thing will be to keep an eye on this woman and keep her well connected in terms of follow-up. I think the recommendations are that follow-up occurs at least 12 monthly, and certainly for most women who've been diagnosed, they will probably seek some sort of follow-up within the first 6 months, and certainly that's the way I would be heading them, and then probably 12 monthly after that, and that would involve coming hopefully to see me as their GP. I would do a clinical examination and then send them for appropriate mammography and or ultrasound.
Chris?
I'd agree with that. We need to remember both the treated breast and the opposite breast, and that's an important part of both physical examination and the imaging.
So the woman is at increased risk of contralateral disease.
Yep.
And what's the mammography regime then for, if you had a total mastectomy, do you still do mammography on that breast? What's the story?
For the other breast, but not
just on the contralateral side, but you don't do it on the chest wall or anything like that.
I think it's just important to mention the rate of the risk of recurrence, the risk of future breast cancer in the ipsilateral breast or contralateral breast is 4 times higher than the normal population. So that's the importance of the
it's still fairly low, isn't it? I mean, it's 5% at 5 years and roughly 10% at 10 years. So of invasive cancer developing in
but that's the reason for the annual screening.
Yes.
That's right.
That's not the usual recommendation of 2 yearly screening in the general population. These ladies need annual screening.
So it's a higher risk, and it's interesting that 90 to 95% of women over a 10-year and 5-year period respectively are not going to get any recurrence. Yeah, so it's fairly safe.
So given this woman's going to have 5 or 6, let's say it wasn't Susan and she had disseminated disease in that breast and you did a mastectomy, we underdo breast reconstruction in Australia by a vast proportion, is my understanding of the National Breast and Ovarian Cancer Centre surveys.
That's probably a fair comment, yes.
But let's assume that she's offered that opportunity. What's the story here that you advise women on in terms of immediate reconstruction versus delayed, given that she's going to have radiotherapy?
She wouldn't.
She won't have radiotherapy after a mastectomy.
No.
So if it's a mistake, the problem's solved.
She would be an ideal candidate for immediate reconstruction, and I would be strongly recommending
because she's not going to have
that.
chemo, and therefore there's going to be nothing in the way of that.
And the risk of her recurrence is extremely low. It's 1% or less. So it's extremely low.
And the reason for no radiotherapy after mastectomy is that such little tissue is left that you consider the risk low of local recurrence.
And as has just been said, the rate of recurrence is so low after mastectomy.
And is chemo or hormonal therapy ever indicated?
Chemotherapy is never indicated for in situ disease. I think the potential role of hormonal therapy is somewhat more controversial. If it's used, it's generally restricted to those situations with a high risk of recurrent contralateral disease, and we do start to get into shaky ground as to whether
the knowledge base is weak. Yeah. And clinical trials, are there many clinical trials running at the moment recruiting in DCIS? Because given the standard of care is not just multidisciplinary team-based care, it's also being offered the chance to enter a clinical trial. Hard for women sometimes in country areas to do that, but you would want them to have access to the latest therapies. What's the story in terms of current trials?
There are clinical trials ongoing, and Brendan might like to comment on some of those trials that are attempting to better define the group who are managed with breast conserving surgery, where we might more safely omit the adjuvant radiotherapy.
Yes, there's a couple that have closed, and we've got some data back on those, looking at mainly using tamoxifen, aromatase inhibitors and so on. But there's several that are open, and part of the problem too is that there's new inhibitors coming onto the market all the time, and it takes a fair amount of time to follow these patients up. So there's about 7 trials available around the world, some of which are available in Australia, and of course those haven't closed yet and the results aren't in, but they're trying a range of different aromatase inhibitors and different SERMs and so forth, and tamoxifen as well.
Susan comes back to see you, Jenny. She's had a radiation therapy. She believes what she's been told by Professor Milross, that the chances of cure here are really high, that she's really not going to get disease back, but she just feels lousy, she feels depressed. It's just been a pretty unpleasant experience from her. Sexual relations with her husband are not back to normal. She's just feeling low, and the scar is a bit bigger than she expected on her breast, even though it was breast conserving surgery. How often do you experience that sort of conversation? Very
often. Norman, I would think that would be upwards of the norm. For most women, this is an extremely confronting experience. And as I said earlier, for those women, the difference between invasive cancer and DCIS is a pathological one rather than one that they've experienced
because for them it is cancer.
It is cancer, and from Susan's point of view, she's undergone mutilating surgery and she's had her life threatened. So they're both very significant adjustments. Now, I think the strange thing is that not every woman reports that, and obviously women deal with some of these issues in very different ways. But I would certainly try and legitimise and support those feelings that Susan's having. And
would you wait for her to come to you, or are you more proactive in wanting to see women afterwards? Because there's a debate either way, is that you could force a counselling session on her when she actually doesn't want it or she's not ready to talk about it. So it sounds good to do a follow-up, but she might not want it. What's the story? What do you do?
I make myself available, but I don't go chasing women,
forcing them to talk.
Forcing them to and nor expecting them to sort of go through, numbness, anger, and a sort of a process-oriented way from what is, as I said, a very traumatic experience. I think Lee, and this is where, again, one's not operating in isolation. This person will no doubt be talking to their family, friends and to their breast care nurse, and this is an experience widely held in the community. There are many, many women in that age group who are survivors of breast cancer, and they'll be out there talking to Susan.
Well, and giving 17 different pieces of advice, no doubt.
Probably.
So Lee, what's the approach here in terms of helping a woman through this? Is talking enough, or what are the techniques that either nurses or doctors can employ to help a woman through this time?
I think talking is a really good starting point, because often the women aren't going to raise these issues themselves, and I guess as a breast nurse, it's about contacting these women and letting them know that you are actually going to contact them on, maybe in so many weeks' time and so many weeks' time after that, and starting the conversation and then just being fairly open with questions, and lo and behold, you do often get a great discussion about the issues that they're facing and the difficulties that they're experiencing. And I think that realising that there is somebody who's actually going to raise those issues and validate their feelings is really, really important. And I think what Jenny's saying is very important. It is about liaison, so it's open communication with all members of the treating team, and also too making sure that there are support groups that the woman can go to, because it doesn't matter whether...
In country towns, they are available?
They are available. There's also chat rooms, there's also online groups, there's telephone groups.
Now we're just showing some of the places that people can go in terms of Cancer Council, NBOCC and indeed the Breast Cancer Network of Australia.
Women to them it's not, I've got to find a support group where somebody else has had DCIS. I've had a cancer diagnosis and I want to talk to somebody else who's had a cancer diagnosis.
Yeah, because they don't differentiate.
No.
And what about the poor blokes?
What about the poor blokes?
You know them, really the ones at home?
Those support people. I think that they do it really tough too, because they don't know what to do and what to say, and men in general are fixers and doers. So when you start to talk to women, they may be seen in the community, their male partners may be seen in the community as not being terribly supportive, but in actual fact they're doing things like mowing the grass or shopping, or those things that they think are actually going to help. But I think again it's ensuring that you're able to talk to both of them, raise issues with both of them.
And sometimes it will slip into frank depression.
Yeah.
Oh, certainly, and you need to be on the watch for that, and intervene where appropriate.
Most cancer in men, occupies about 1% of all breast cancers, is more advanced. It should be able to be diagnosed earlier, but it's not. It generally is more advanced.
Do you get DCIS in men?
Yes, of course, I'm sure.
But you haven't seen it.
It's something that I'm sure goes,
but it goes
unnoticed. I mean, have you ever seen mammograms?
I've never seen DCIS in men.
But I was actually talking about men without breast cancer who just have to support the woman with it, but it's a good point. Look, that's been a fascinating discussion, and I've learned a lot about DCIS. I've been asking a few stupid questions tonight, but that's my role. What are your take-home messages for those watching? Chris Milros?
The goal of treatment is reduction in the risk of recurrence of both in situ and, perhaps more importantly, invasive breast cancer. And that, secondly, for patients who elect to be treated with breast conserving surgery, that radiotherapy is an important adjunct to that treatment that is proven to be beneficial and that is well tolerated.
Lee?
I think effective communication on all levels, the woman, the family, the treatment team, and I think normalising and validating their feelings and concerns.
Jenny?
Well, it definitely is a team approach, and I guess the other thing I'd like to say is that it has to happen over time, so the real importance of continuing surveillance and support so that women continue to access mammography and keep the rates of recurrence as low as they can possibly be.
Warwick?
I'd like to get back to early detection and encourage women and encourage the GPs to ask their women to involve themselves in breast screening.
Brendan?
I think it's important to emphasise to the woman that she really, has a cancer that has a very good prognosis overall. That the risk, although it's there, is low, and that she needs regular follow-up and regular mammograms and surveillance. Also, that if it were to come back, then the overall picture is better than for the average cancer. The rate
It's almost like a first diagnosis.
Yeah, the rate of nodes being positive is only about a third. So 2/3 of the cases are going to have negative nodes, which puts them in a better prognostic group as well. So, it's not hopeless. That's the message, and it's very important to get that through to the woman. At the same time, not to discount it, because they go through all the trauma that a woman with an invasive breast cancer goes through quite often.
Thank you all very much indeed. I hope you've got a lot from this programme on ductal carcinoma in situ. Our thanks to the National Breast and Ovarian Cancer Centre for making the programme possible, but thanks to you for taking the time to attend and contribute and ask so many questions. If you're interested in obtaining more information about the issues or resources that we've talked about tonight, there are a number available on the NBOCC website, nbocc.org.au. Don't forget that decision tool. And on the Rural Health Education Foundation website as well, rhef.com.au. Don't forget to complete and send in your evaluation forms to register for CBD points. I'm Norman Swan, and I'll see you next time.